pathology comes in. I'll put that, yep, got it. So that's where speech pathology, so that was the career that I loved. That was my passion, my career as a performer. And then I realized there were these people called speech pathologists who were helping a lot of my friends who had vocal nodules, who had vocal pathology because of overuse of their voice. And I was like, wow, that seems really interesting. That seems like a field where I can maybe come in and use my expertise as a singer to help people. So I applied to grad school. I took a class at Brooklyn College in what was it, the physiology of speech, the speech mechanism, just as like an intro, and I loved it. I thought it was great. So I decided to pursue a graduate degree. I went to NYU's program, and that's where I kind of made my transition into this career that I really, really love and feel what I was meant to do. While I was at NYU, we'll get into the bilingual piece. So I am not a bilingual in the traditional sense of having been raised in a household where people speak another language. My primary language is English, but I always loved languages. And when I was in high school and college, I studied abroad in France for a year. I studied abroad in Barcelona for about 4 months. So I always loved languages and knew that I wanted to use my languages. And as a performer, I used my languages a lot when I was traveling. So I came into the NYU's program hearing about this bilingual extension. And at first, I didn't know if I would qualify because I'm not a native Spanish speaker. But with practice and just with using my skills and my Spanish in the field, I actually got to the point where I was proficient. So that's one thing that a lot of people, they get very nervous, like, oh my God, like I'm a bilingual, but am I really a bilingual? Like, I don't speak Spanish every day, or, Mandarin or Cantonese or, Tagalog or whatever language you speak. And there are different, you all know this, there are different gradations of bilingualism, and we need you. We need people who are multilingual, who are multicultural. So, you will learn on the go, and your skills will get better if you're not a native speaker. So at NYU, one of the challenges I had at NYU actually was that when I was a career changer, so I was a bit older than everyone in the program. So I had a job, I had to work. So I was working while I was in grad school. I'm sure a lot of you guys are working while you're in school. And then during my last semesters, when I was about to go into my off-campus clinical placement, so I had finished my coursework and I was getting ready to do like a pediatric placement. I got pregnant. So I had met, a very lovely man that I knew I wanted to be with, wanted to start a family, and I was pregnant during my pediatric outpatient clinical placement, had my baby, came back, did my adult placement at Weill Cornell in acute care, and then graduated with my baby strapped to me, walking down the aisle. So that was that. And then in terms of getting my C's, I got my C's in a nursing home, it was like a subacute rehab / nursing home in Brooklyn. I was there for about a year. I was there during COVID, which was a crazy experience. And then and again, this goes back to, you probably have all heard this, the importance of having connections, the importance of keeping in touch with your professors and with your colleagues. One of my professors at NYU is a supervisor in the acute inpatient rehab unit at NYU Orthopedic Hospital. So one of their speech pathologists left. I had kept in touch with her and with a bunch of other professors at NYU. And I interviewed for the job. And in 2021, I joined the team at NYU on the brain injury unit. And that's where Anaya was during the summer. So should I pause for questions now, or just kind of keep going and do the questions at the end, Anaya?
I think it's okay does anyone have any questions up until this point? You can say in the chat, unmute yourself, or if anyone in the room has any questions about career changing or anything Jennifer said so far. No? Okay. So I think you can keep going for now
Yeah,
then.
I'll keep going. Yes, that's kind of my background. And then, so what do I do at NYU? You all know that, like, speech pathologists, this is such a rich field. You can work with kids, you can work with adults, you can work inpatient, outpatient, you can work privately. There's so much you can do. My unit is very unique and special in that, okay, so I'll lay it out. So say you have a stroke, God forbid. You have a stroke, you go to the emergency room, you're in the hospital, so you're at acute care, which is like the highest level of care, right? They're trying to save your life. So you're in acute care at the hospital. You're not going to stay there forever, right? Like at some point you're stabilized and either you go home because thank goodness you're well enough that you can go home, or you go to maybe a subacute rehab, which is a rehab where maybe you need like a couple of months to get stronger. You have a hemiparesis, you have, you know, you have a feeding tube, you have nursing needs. Maybe you go to another facility where you can spend like maybe, you know, anywhere from like call it a month to like 3 months getting better. I'm in the middle layer of care. So acute rehab is a place where you would go after being acutely ill. And the goal there, you would spend maybe about, call it 2 weeks to maybe 3 weeks getting better, with the idea that you're doing intensive rehab, 3 hours of rehab every day. And we really want to get you home after that. So we're really, and we're also choosing patients who still have acute medical needs. So patients who have trachs, patients who have PEGs, patients who may have infections, patients who, may be, kind of not really fully comatose, but in what we call disorders of consciousness, where they're kind of in between being, conscious and not. So that's where I come in. I work on a 58-bed unit. There's 2 floors, and I'm part of an interdisciplinary team. So I work with physical therapy, occupational therapy, there's speech, nursing. And then on top of that, we have all of our medical team. We have medical staff on, there all the time. We have residents, we have attendings, we have psychologists, neurologists, dietitians, radiologists. So as a member of that team, we are all dedicated to our patients, and our patients tend to be people who've had brain injuries. So we specialize in people who've had strokes, traumatic brain injuries, brain tumors. Sometimes we get like some Guillain-Barré, like some of the MS, some of the neurological disorders. And I'm just looking back at my notes here. Okay, great. And as a speech pathologist there, I'm treating patients who have swallowing disorders. So I do modified barium swallow studies. And then also we do a lot of treatment for patients with cognitive disorders, acquired language disorders, like patients who have apraxia of speech. So it's a broad range that we're looking at. And as a speech pathologist there, I probably see about 5 patients a day. I do 1-hour sessions with the patients. And a lot of my job is either rehabilitating that person's language abilities. So I have an aphasic patient right now, very aphasic. So like he can barely get any words out. I'm trying to figure out how I can give him a communication board, how we can work on him producing some more clear language. And then I have a patient who is, who can speak just fine, but he had a traumatic brain injury and his judgment is really poor and his memory is terrible. So just trying to figure out how to like give him memory strategies and to help him build a little bit more safety awareness. What you do in this setting is a lot of education with the patients, a lot of education with the families. So the families are there. They're almost like as much your client as the patient. So to work in this setting, and I'm going to get into the obstacles of being a minority in a minute. But if you are considering, and I know you guys are like very much in the beginning of your careers here, but if you are considering a career as a medical speech language pathologist, one obstacle is you have to learn the medicine. We do not learn the medicine in school. We don't learn it in undergrad. We don't learn it in grad school. So you have to learn a little bit about the medicine, right? What is sepsis? Why, if someone, what are the underlying mechanisms behind a stroke, right? why, if, someone has cardiac issues, why that might impact their speech and swallowing. So these are things that like you go in and you have to kind of learn on your own. So you need to be hungry and you need to put that extra work in. So if you don't have the time or you're not able to put the time towards learning a bit more about the medicine, then this is not going to be the place for you. The other obstacle is time management. There is no time in a hospital. You barely have time to get prepared for your sessions and to write your notes and to, do all your planning and to do education with the family. So you really have to be a very good time manager. When I've had students that I've worked with, one of the biggest things that they've had trouble with, and it's something that comes with time, has been time management. There's no dilly-dallying, there's no scrolling through Instagram, there's no time. There's just no time to do it. And then the third obstacle, or not obstacle, but the third thing you really need to have are interpersonal skills. So you're working with doctors, you're working with, with the patient, you're working with nursing staff. There's a big team of people, and it's a hard job. It's a hard job, especially, you have a patient care technician whose job is to make sure that the patient, when they soil themselves, that they clean them, that they get them in a chair so that they're ready for therapy, that they shower them. That is hard work. It's really hard work. So, to talk with people with respect, from everyone from the person who cleans the bathroom to the attending physician who's calling all the shots at the top. You really have to have really good interpersonal skills. Okay, I'll take a little pause there if anyone has any questions about acute inpatient rehab. And you can unmute yourself. It's okay. Let's check the chat.
We have a question here, Jennifer.
Uh-huh.
Someone wants to know, so you've spoken a lot about like judgment and patients needing assistance with things that are not so much related to speech and things that we might learn in our undergraduate and grad. Kind of sounds like more cog. Can you speak a little bit about that?
Yeah, sure. So for brain injury, I do so much cognitive rehab. We don't think about the fact that, so I feel like even in grad school, you learn about, in undergrad, you learn about like Broca's area and, Wernicke's area and the, kind of, left neglect, all the basic, the heavy hitters, the big ones, right? And we get a lot of that, right? I have tons of aphasia. But if you think about it, those same areas of the brain, your frontal lobe, your parietal lobe, your temporal lobe, those same areas of the brain have areas that are involved in memory, that have areas involved in, in spatial awareness, that are involved in attention. So, if you have someone who has aphasia, it is possible that maybe they're not going to be able to pay attention to a task very long because their injury wasn't a part of the brain that moderates their attention. So so for cognitive therapy, you're doing a lot. There are like a bunch of different apps and there's a bunch of different worksheets that we can use, and you can tailor things to the patient as well, to kind of address the cognition. And then it gets to be really interesting when you're addressing language and cognition impairments in someone who doesn't speak English, and you're trying to come up with therapy materials in Mandarin or in, Russian or Spanish. And there are some resources out there, but as a bilingual provider, that's one of the challenges, is that we don't have as many resources a lot of times in terms of therapy materials and in terms of even testing materials for patients who don't speak English. I think I saw something in the chat. Oh, okay, thank you for bringing about needing to know your medical terminology. Yes, there's a big push for this in the speech world. There's a lot of people who are really, very focused on making sure that this profession gets the respect that is due to it, and part of it is, really knowing the medicine behind it, because your colleagues in physical therapy and occupational therapy, they get some of that medicine as part of their training, and it's not really ingrained in our training yet, but there's a push for it.
We do have another question.
Mhm.
Someone wants to know how you make your treatment plans to kind of address both language and cognitive skills.
Yeah, yeah, that's a great point. So, some of it depends on like how impaired the person's language is. So if a person has aphasia, and they're very severe aphasia, like it's really hard for them to speak, it's really hard for them to communicate. Sometimes, but at the same time, they have some cognitive difficulties, right? Like, so I know that they're really not like carrying over or understand. They're really not remembering like orientation information, like where they are, what happened, their memory's poor, or their attention's off. I kind of have to make a choice because there's the language piece that's the most important. So maybe I'm targeting, attention, okay, because I want them to pay attention to something for at least 5 to 10 minutes, and I'm targeting that by doing a confrontation naming task where I'm showing them. I'm both targeting the language and I'm also targeting the cognition. So it all depends. But if someone is like a mild aphasic, right? Once in a while they have trouble finding their words, but they are like all their memory's terrible, like they're all over the place. Then I'm going to prioritize the cognitive goals. Oops.
Hi, sorry, we do have one more question.
Mhm.
Someone wants to know if you have had any instances where your professional opinion wasn't really taken into consideration because, like, you have like lots of attendings, lots of other doctors and therapists also involved in
Ask
treatment.
away, Anaya.
Sorry about my Siri. But yes, that's what so that's someone's question.
Oh yeah, that's a great question. So that kind of gets into like we'll get in that perfect question to get into like kind of the obstacles, right? So yeah, no, I've definitely had situations, and I think this doesn't only happen to me as a person of color, but it happens to a lot of us. I've definitely had situations, especially on the swallowing point, dysphagia, right? Where I may see a patient, I'll do a swallow study, I'll make a recommendation, and I've had a doctor or two say, you know what, I don't want to do that, especially in acute care. So not in my current position. Most of the doctors will respect what our recommendations are, but in acute care, when this person is like, they could go either way. They're in the ICU, like, there's a lot of things to consider. I might make a recommendation. So maybe I say, you know what, I think this person is safe enough to start a diet. Maybe they're MPO, they're not eating anything. I do a swallow study and I'm like, okay, it looks like they're safe swallowing puree and maybe a thickened liquid. I think we should start them on a diet. The doctor may say no. They may say no, like, I think that this person has a lot of oxygen needs that, they can kind of very quickly go the other way and may need to be reintubated or may need to, have, something may happen. And I don't think they're safe eating. So it's more, I've been more overruled. It hasn't really happened much because again, in a hospital environment, I feel like the doctors very much appreciate and respect the speech pathologist in terms of swallowing. But I have had doctors say like, no, I think it's too dangerous. And that's fine because again, understanding that medical piece, there may be some other underlying factors that may make it, a little bit more dangerous for that person to eat.
We do have another question. A
Mhm.
student wants to know, since you were working, how you balanced your time with grad school life and, eventually getting to this point of being able to manage your time really well. You said that this is something that comes with time, so a student has a question about that.
Yeah, yeah, no, I think it's something that comes, you have to be very organized. And everyone has their a way of being organized. So some people make lists, some people make paper lists, some people make list, in their phones. So I think for me, like making a list is really important, and knowing my priorities. And then part of it is just, I kind of set realistic goals for what I want to do that day. So when I come in the morning, I write out my schedule. Okay, I have to see Mr. Smith, Miss Francis, or whatever. And I kind of set out like what I need to do with each of them and what needs to be done, like in terms of paperwork. So like I'm just crossing stuff off the list. And in terms of managing things with like family, that is always like, and just life in general, that's always like a balancing act. I'm sure you guys are dealing with that now too. And I would say the biggest suggestion I have is like when it's time to be done with work, be done with work and be present and with your family or your friends. And work will always be there. Just a matter of just prioritizing what needs to get done. There's always something to do. And when you're with your people, and you have that time and make it be precious. I see some stuff in the chat. Let's see. Would you start your own SLP practice? And if you already have one, how did you get it started? That's a great question. That's something I have thought about, especially here in New York, especially if you are a bilingual potential, and especially if you're willing to travel. So if you're willing to go to Brooklyn, to Queens, to the Bronx, and just not be in the city, there are opportunities for people to be in private practice. I have not done that. Just one, I really love working in a hospital environment. I love being like as part of a team. So, as interesting as it would be to like kind of be able to manage my own time and my own schedule. I haven't thought about that yet. That being said, I have worked with patients privately. And it can be a very like, you can be rewarded handsomely for doing so to speak. But there's all sorts of logistics, and there's a lot of resources out there through ASHA on setting up a private SLP practice. But I would say like definitely it's something, if you're interested in it, there will be a need for it, because I'm always asked like, will you see this person? Will you come here or do this? And I'm like, nope, I can't do it. I have a full-time job. So there's definitely a need for it. There was another question here. Would you say those type of occurrences usually happen in terms of the topic as you shared regarding moving a patient from MPO to PO and weaning people off a feeding tube? Okay, great. So yeah, so that question I had, that question I had about, has anyone ever challenged my my expertise or my recommendations? Yeah, it's usually in regards to that. Because that's, again, like, and it usually happens in acute care. Also, sometimes you will be challenged by the family. Like, so I had a patient recently. He came in on a thickened liquid, and then I did his modified barium swallow study, and thin liquids looked really good. He really didn't need to be on a thickened liquid anymore. And I recommend to the family that we put him on thins, put him on regular liquid, just, watch him control his volume. And they really felt like, because he was a little impulsive and it was hard to, like, sometimes you take these like huge sips, you're like, oh my God, what are you doing? Because he was a little impulsive, they wanted to keep him on the nectar, the mildly thick, because they felt like, that would give him a little bit more independence. So if they're not in the room, he could just drink and they don't have to be like hovering on top of him. So it's always a conversation in the end. You just want to like do what's best for the patient. Okay, let's see what we have here. Has there ever been, or is there an occasional issue of difficulty with trialing new food consistencies with patients when patients are resistant to the types of food offered? So, for example, trialing puree and patients dislike puree. Yeah, we've definitely had that issue before, where patients don't want to try certain consistencies, especially like if you have like some of your patients who maybe have dementia. Like, dementia patients are very sensory. Certain, like puree just may seem really yucky to them. And it's kind of it's a tricky thing to do, because if you want to give someone things, but you can't force them. So in a lot of instances, for example, maybe someone doesn't want to have puree, they really feel like they can eat regular food. You might have to go in and give them something regular, and then see them fail at doing it. So maybe they can't chew it because they don't have teeth, or because, they have really poor tongue strength. And you try to do it in front of the family so they understand it, and you see, you set them up, and they acknowledge, oh my God, I really can't eat this. I wouldn't be able to eat chicken. So that's one way you kind of get around it, but it's a tough situation. It can be. Let's see. Oh, in terms of picky eaters or drinkers, unhappy with oh yeah. And then with picky eaters and drinkers, so we have a lot of that too, and especially like when you're treating multilingual, multicultural populations. So like, when you think about it, a lot of times some of these folks who are at the hospital, they have never been hospitalized before. And some of them, live in New York, it's very possible to like not speak English, and given depending on what community you're at. So you could live in a community where you don't have to speak English every day because your community has stores and doctors and services there. So all of a sudden you're in this hospital where like everyone speaks English, you don't understand them, they don't understand you, and they're giving you this food and you're like, what the hell is this? Like, I've never eaten this before. Like, I eat kanji, like I eat I eat dal. I don't eat these things. So that's where you really have to get the family involved and be very mindful culturally that like, yeah, this person isn't eating because they've never eaten this before in their life. Like, they've been eating food. This is not really culturally appropriate food for them. And that's where, like, thankfully, a lot of those cases, the family's involved and they can come in and they can bring food, and we can kind of get that person appropriately hydrated and fed. Yes, that gets to the next question. Do hospitals allow family to bring in home cooked meals or food to match the child food consistency? Absolutely. So I'll always encourage that. When we have patients that are like, who have dysphagia, so ITSE, are you guys familiar with ITSE? Okay, so like ITSE has standards and training for how to thicken liquids. I'll dedicate like entire sessions to training the family, especially if that patient's going home, training them on how to appropriately thicken the liquids, do the ITSE flow test, where to get the thickening packets, all of that stuff. And I absolutely tell patients, like, bring the food in. Like, I will change my session so that it is at 12 o'clock so that I can be there when the patient's trialing this food. So absolutely. That's a great question. You guys have great questions. All right. So I want to talk about being a minority, right? Or being a person of color and all that stuff, right? So I think, I feel very lucky. And I feel like being here in New York, like, people are used to different cultures. You're used to, like, one block, you may have an Orthodox Jewish community, and in the next block, you may have like a Cantonese speaking community. Like, so we're very used to like different cultures of being side by side. That being said, like, yes, there is ignorance, there is racism, there are people who who are very narrow-minded. I feel like at NYU, I've been lucky, or our chief medical officer is a Black Haitian man. So, it's great that, and we have people of color in all, pockets of the hospital. Our the chief attending of the brain injury unit, Dr. Im, is an Asian man. So, we have a lot of different representation going on in terms of people of color. That being said, I feel like, and I've never gotten over this, like, you still feel like what they call that imposter syndrome at times. Like, do I really belong here? Am I here because like someone decided to like affirmative action, or because like, did I really merit this? Did I really earn this? And I've had to like, it makes me like want to work harder and want to prove myself. And, I've definitely had that. And there's definitely been times where I've walked into a room and like, I can see like the families are like, oh, like, who's this coming in? And then and then at that point, like, it's about building confidence. At this point, like, I know that I'm keeping up with the literature. I know I'm keeping up with the research. I know what the hell I'm talking about. So then like, let your knowledge do the talking. And, it's very easy to get into your feelings and feel like, a hostility or animosity terms of, you know, how people may perceive you. But I just kind of like take a breath, take a moment, and just say, I know what I'm talking about. I've been trained, and I know more about this than this person does because they are not a speech pathologist. And just rely on your knowledge, and people usually respond very well to that, and it can overcome a lot of obstacles. Not all of them. There's still people who can be narrow-minded, but it will really help you in the end.
Someone wants to know if you faced these similar issues while you were completing your grad school program, or when you were in clinic afterwards doing your CF, in spaces outside of NYU or in other job experiences.
Yeah, I mean, I feel like when you're a student and you're doing like your placements and your CF, like you probably, I would say you probably feel a little bit more of that because you don't have experience. Like you really don't know what you're doing. Like, you know, like you have the knowledge, but you're trying to like put it in action, right? And then like on top of that, like you may come across someone who, because you speak, you know, you look a certain way, is immediately assuming that you don't know what you're doing. So that's like, that's on top of it, right? So, I mean, again, like as a student, like as you, when you're just starting out, that's why it's important to like, you know the knowledge, like know the literature, know, you know, keep your notes, okay? Because in the end, like even if you don't have a lot of experience, if you can rely on, if you know where to get it from, if you know where to get that information from, and if you're humble enough to say, you know what, I don't know, I will ask someone, because people will respect that, then that will help you. But so yes, so people, you are going to encounter people from student all the way, if you're like super, super senior speech pathologist, who may look at you as a person of color and make certain assumptions. You have to rely on the knowledge. And in the end, I also, if you, especially if you're dealing with patient care, I think about the fact that like in the end, it's that the patient needs to benefit from whatever it is I'm doing. So, you know, if I have a difficult family member, like that is annoying and I have to deal with that. But in the end, like my patient is the one that needs to get better. And if I'm showing that I'm getting this patient better and things are happening, I'm hoping that that's going to make the interaction a little bit better.
We have one question.
In grad school, did you feel like any, I guess, like animosity or any like issues like within your cohort, not necessarily like interaction with professors, but like interaction with your cohort?
It's a really good question. I'm not sure if you were able to hear
I
her.
heard some of it. Yeah. So in grad school, did I ever experience any animosity with professors or?
Not with
Oh,
professors, but with within your cohort, within the other people that you were studying with,
ah,
or in how you navigated that, if possible.
I'm trying to think. You know what? I did not personally, but definitely like I went to, you know, I had colleagues who had to deal with little microaggressions from other students, who made assumptions about them. And that was really uncomfortable. And I feel like there were at some point at NYU, it was addressed on like a broader scale, where faculty got involved because there were all these little things that people will say to you, right? So, you know, I did not personally, but like again, like it does happen. It does happen. And, you know, it's always so tricky to like figure out how to like handle it in the moment. Sometimes it like takes you off guard and you don't even realize what's happening, and you step back and you're like, but wait a minute, what just happened here? You know, and you know, there's been times where I've you know, depending on who that person is, if I have a relationship with them, I've gone back and I've said, listen, like, you know, that assumption that you made, it was like a colleague, for example, or like a fellow student, that's that assumption you made, you know, that really kind of, you know, that hurt my feelings, or like, you know, that was incorrect and we should talk about it. So other times, you know, especially if it's someone like who may be like older than you or senior than you, that's a little bit tougher too. Um, you know, it sucks that like as a person of color, you always have this in the back of your head, like that someone might say something stupid or someone might, you know, challenge my authority. And again, I feel like, you know, I kind of you kind of build up, if you could build up that confidence, so not arrogance, but that confidence, like I know what I'm doing, like, you know, you know, I'm continually learning, I'm continually trying to get better in my field. That is going to shine through. Your knowledge is, and your intent, right? So your intent, your empathy, your compassion for the patients, that will shine through those moments. And I've had people, you know, families or people who I've gotten them on my side, right? Like maybe they still have something against people of color, but you know, I did everything I could for their loved one, and in that moment, and that their loved one was the most important part. So yeah.
We have one more question.
Mhm.
I had a question about advocating for yourself, whether like in the classroom or on your externships or whether like finding a job in like a certain area that you want.
Were you able to hear that, Jennifer?
Mm-mm.
We had a student ask, how do you advocate for yourself in different contexts? So within your externship, in grad school, in your career, different settings, things like that. How do you
Mm-hmm.
advocate for yourself?
Yeah, sure. I mean, you know, part of having advocating for yourself is knowing like who are your people and who are your people who are going to, you know, support you. So, you know, I'm very lucky. Like my supervisor is definitely someone who has helped me advocate for myself and who has advocated for me. But you know, I mean, basically, you know, you know, for example, so I was recently promoted to senior, right, to a senior speech pathology position. So I made a list. I advocated for myself. I made a list of all of the things that I had done. And in the thing in medicine, especially at NYU, there are specific metrics. So medicine is like, you know, I'm sure there's bad doctors out there, but like a really bad doctor can kill someone, right? So, you know, you can't be that bad. Okay. So there's certain metrics. So, you know, there's certain things that I had to do to become promoted. So I wrote out a list. I was like, I've done this, I did it within this time period, I've gotten this, and made sure that like you know, I used one of the other senior speech pathologists, kind of ran it by her to make sure it looked good. And then I finally got it to my supervisor. But, you know, I would say like, again, like advocating for yourself, saying this is where I'm at, like this is what I've done, especially if it comes to, you know, down to a promotion or whatever. Or even just like advocating for things that you may need in order to do your job better, right? So maybe your department needs resources. Maybe, you know, as a bilingual, for example, like, you know, advocating for the fact that, okay, having data, half of our patients who came in don't speak English. They speak a language other than English. Why do we only have 2 tests that we can give to them, you know, in order to assess language and cognition? So having the data, like, here's the data, like, this is our patient population. We're not properly representing them, or we're not properly evaluating them if we don't have the right materials. We need to get them. Here's what we can get. So that I would say, like, have the backup data, in order to help you advocate for you and your patients.
I think that's all that we have relating to your experience, like as a minority within the field. But going back to what you're talking about, just in your everyday life at NYU, um, I have one other person in the room here who did the HCOT program, but
Oh, nice.
everyone else has not. So they would love to know like a day in your life or what it's like shadowing with an intern.
Yeah, sure. So I work a 8:15 to 4:15 schedule. So I usually try to get in between 8:15, because I see my first patient at 9 o'clock. So between checking emails, checking the schedule, checking through chats, checking through any kind of communication between the team, it doesn't give you a lot of time to prep your sessions. So, you kind of have to go in very mindfully, kind of get stuff done. And I usually see patients, so I can see up to 5 patients a day, 5 at 1 hour sessions. So I'll see patients from 9 to 12, have a little lunch, probably type up some notes during lunch. And then from 1 to 3, I see patients again. And again, during all that time, so 5 hours, it's 5 hours not only to do treatment, but also to pull together your treatment materials, write up your notes, um, you know, talk to the families if you need to do education with the families, any kind of communication you have with the teams. So a lot is packed in one day. I'm trying to think. And then and when you have a student shadowing you, that adds a little bit. I love having students. And I always try to, like, even if I have to cut a session like 5 minutes short, or kind of be a little bit late to another session, or be a little late to lunch, I'd rather have that, so that like I can like talk to the student and ask them what they thought, what they saw, because that is like the fun thing. Like I feel like with speech pathology, it's important, especially in a medical setting, that we like kind of mirror our sister disciplines and have that culture of like mentorship, and have that culture of having students. So, because that's how doctors learn. Doctors are not attendings right out of school. They become residents, and they're working under another senior doctor. So I love having students. I love having them come in, and you guys ask all sorts of fun questions and things that like you see that like as a experienced clinician, I'm like, oh wait, I never thought about it like that. But yes, like with fresh eyes, yes, that's like absolutely like a great observation.
I have a question. I was wondering, you mentioned earlier about being well informed, especially when working in medicine and knowing all of those terms and how they might affect a patient when you're treating them for speech. How do you stay up on that? How do you make sure that you're always like understanding of what's going on with a specific patient? What resources maybe did you use, or do they have anything at at NYU that you were able to take advantage of that helped you remain clinically competent? Anything like that?
Yeah, sure. So during one of my placements at Weill Cornell, when I did acute care, um, so when a patient comes in, you read something called, like, it's like a history. It's called H&P, and it basically summarizes like everything that happened to that patient. And there's all this terminology. This person has HLD, HTN, CAD. So I was like, what did all these terms mean? So ASHA, actually, on their website, they have a medical abbreviation, like a medical terminology, like cheat sheet that you can go. It's free. You can download it. I think just type in like asha.org and in medical terminology, or Google it, and you can find it. And that's like a really good place to start. And then, just things like WebMD is great. It's a pretty reputable source, because something like hypertension or coronary artery disease or stroke. So they will actually like break it down and give the basics, because that education is designed for patients and their families. So that's like a really good, it's not going to go super in depth, but it's pretty good to give you an idea of like what things are, just what is it, right? And then there are courses out there that are designed to educate speech pathologists on some of the more common medical things that we'll come across. So on Northern Speech Services, I took a course taught by Jim Coyle. He's at the University of Maryland. He's unbelievable. He focuses more on dysphagia. But Jim Coyle's class is fantastic. It is a marathon of a class. I would say, it'd be great if you can take it and get it for continuing education credit. Because it is like, it's a couple $100, it's expensive. But I thought that class was excellent because he talks specifically about what patients may have in acute care and how that may affect their speech and swallowing. So that's a really good resource there. And then again, interpersonal skills, like I get real friendly with the nurses and I will ask a nurse, like if she has a free minute, I'll be like, listen, like this patient has like a PIC line, like what exactly is the difference between that and a midline and an IV? And I just, and they love it. They love that like someone's asking them about something related to what they do every day. And I just ask questions. One of the nurse practitioners, I'm like, so this person has this, like, well, why are they desatting into like the 80% range? So, use your people too, use your resources. They love talking about stuff like that. They're nerds.
I did want to ask if you had any experience working with children in a medical setting, and if that differed from how that differed from working with adults in medical setting, if you did.
Yeah, I have not. So when I was at Weill Cornell, I observed one of the pediatric speech pathologists in the NICU. So in a medical setting, the young patients, the kids tend to be like babies in the NICU, where like those babies may be on a vent, they may have trachs, they have feeding tubes. It's a very specialized practice, and there's not a lot of people who do it here in New York. So if that is your passion, like network up the wazoo, because there's not a lot of people who do it. And I saw that and I was like, oh, these babies, I can't, this is too sensitive. I can't do this. So yeah, no, so I've not worked with them. And in the other way, we don't really have a lot of pediatric hospitals here, but you have, in terms of traumatic brain injuries, the largest group of people who have traumatic brain injuries are children from age like 2 to 5 or 2 to 4, and then adults, right? So you're going to have kids who have traumatic brain injuries. We had a unit at LOH, at NYU LOH, but we don't, by the time I arrived, they didn't have that anymore, where we would treat like teenagers or, a 10-year-old who fell off their bike and, had a brain bleed. So I have not personally treated kids in a medical setting, just outpatient. I've taught Spanish-speaking kids bilingually.
We do have one more question. It might be the last one that we have time for today. But just wondering how you, like what kind of sessions do you find to be the most challenging, or what, maybe like how you prepare yourself for that, and how you're able to still have a successful therapy session?
Yeah. I mean, it's, I would say some sessions are challenging. Like if most of our patients like want to be there, they understand that they're there to get better. But sometimes it's challenging when you have a patient who doesn't realize that they have, speech or cognition impairments, and they're a little resistant to having you there. And then that gets a little tricky because you can't go in and be like, here's this worksheet or here's this, exercise, because they're going to be like, I don't need this. So you kind of have to, like, with those patients, I'll try to find out like what they're interested in. Like, so I had a patient one time, he was very against the idea of having speech therapy. He didn't think anything was wrong, but he was like a big, like Formula One race car, like fanatic. And I think I went in and I was like, oh my God, like Brian or whatever his name was, like, I found this article about Formula One. I don't understand a lot of the things in it. Do you think you can like help me out? And he was like, oh my God, yeah, sure. So like I'm targeting a couple of things there. I'm targeting his attention. I'm targeting like, if I have him read it, is he understanding it? Reading comprehension. I'm going to ask him some questions later. Memory. I'm going to ask them some terminology, semantic retrieval. So there's you kind of have to be a little tricky about it. Yeah.
Thank you so much for coming, Jennifer. We
No
all really
problem.
appreciate it. It was such a great opportunity for everyone to hear from you. Yeah, I know I express gratitude for everyone in the room and for everyone on Zoom when I say we were really happy to have you today, and it was really great hearing from you.
Aw, thank you. Good luck, guys. I'm very excited for you, and I appreciate you having me. So thank you. Thank you,
Thank you
guys.
so much.
Good luck. Have a good rest of the semester.
Thank you.
Thanks, everyone.